Yes. And it shouldn't be true, but I think the honest answer is yes. If people recall that when we had the stay-at-home order, or whatever we want to call that a lot of states called shelter in place, we had a stay-at-home order. But at any rate, that was recently extended, if people recall, to I believe May 18th. And then at that point, the governor is potentially looking at opening up in general the public and how we might do that, including the restaurants and public spaces, et cetera. Well, with the hospitals understanding that after May 18th, we're looking at reopening the public, they want to now gain ground, if you will, on reopening the hospitals to more normal operations, including a lot of those elective surgeries that they had put off or canceled when we cleared the institutions so that we could admit COVID-19 patients, and we didn't want the commingling or whatever, so they canceled all those elective surgeries, which was the right thing to do. There is right now the capability of institutions to go ahead and do urgent surgeries, those things, and it's pretty subjective. If the physicians during the patient care feel that the situation is urgent and the patient needs to be seen, there has been some set aside right during the pandemic to be allowing the hospitals to do that. Obviously, there's a great reluctance to do it because you don't want to put patients at risk, and the staff are absolutely stretched to the max with so many of the places being redeployed to the COVID units where our very, very highly intense acute patients are. So as the census for COVID-19 is starting to go down, we don't see necessarily a trailing off yet on the mortality. We're still seeing between 150 and 200 deaths a day here in Massachusetts, which is, a little disturbing. But as far as the number of admissions coming into the hospitals, that has curtailed. So the census inside the hospitals of the number of COVID-19 patients is decreasing. So that's good news, and if you figure the virus runs its course within 3 weeks, we should see that census drop off, and most assuredly, we hopefully see the mortality rates drop off, right? So, yeah, after the 18th, the hospitals are going to want to see a ramping up of the actual back to the normal routine surgeries and just being able to see patients in clinics and whatnot. All of those things are going to want to get back into place. So I think that the governor obviously has put together a commission to start to look at this issue about how to reopen. I think a lot of states are looking at it now, and probably people are hearing about it in the news. The commission that was put together, at least initially, I think it's a little disturbing that there's no one from the front lines of the workforce on that commission, which is not great, and hopefully that will get rectified, because I think one of the fundamental problems that we've had during the pandemic is that people actually performing the work, doing the work on the front lines, really so many things have been given to them to simply do as edicts, as opposed to really pulling them into the decision making so that they can be done properly. Because like anything, if you don't do the work, something might seem fully appropriate, and then when somebody actually is doing the work, they said that won't work because X, Y, and Z. So it really makes much more sense to include the frontline workforce into that commission as well, and I certainly hope that gets rectified soon. Right now, as I said, that commission's coming together. We are going to definitely, as the association, Nurses Association, put in criteria that we think needs to be in place. And when I say criteria, right now our focus is really going to be on how do you reopen the healthcare facilities to more normalized operations. I think that not the level of detail that we will consider when we write to the governor, which will probably be in short order this week, but I think at a minimum there's some fundamental issues that have to be considered. One would be testing. Right now the testing isn't completely accurate, so that's problematic, but more importantly, there needs to be a lot more of it. And that testing needs to be available to any patient that comes into the institution. There should be no circumstance whatsoever where we admit a patient for an elective surgery that we haven't ascertained that that patient has tested negative before they ever arrived in the institution, because we don't want the commingling of patients. And the healthcare staff, we've been fighting this fight for a while about having the healthcare staff. I think if we're ready to open up to normal operations, then every staff member within the healthcare environment should be tested for COVID-19, at least to have a baseline that as of the date that we reopened normal operations, the staff was tested negative. Also, I think the general census of the institutions, as I said before, the number of cases, the admissions are slowing down, and hopefully the mortality is going down. But that may not be true of every single institution in the geographic area of Massachusetts, so we really do need to be institutionally specific. if your institution still has a very high number of COVID patients, that by no means should be opening your doors to normal operations at this point in time. So it might have to be staggered based on regional or pockets areas that are ready to open sooner rather than others. And maybe that needs to be looked at by system, understanding that they're still in a competitive environment. But yeah, the census has to allow that there's enough space to be able to cohort the patients, meaning when I say cohort, I mean we really need to be able to do what we wanted to do originally, was to designate COVID-19 to very specific areas so that they are not intermingled with other patients, and that they have dedicated staff, and that staff has properly trained and has the proper equipment, and that includes ICU as well as regular floor, and the capacity when we have admissions that are not pre-planned, that they can be tested beforehand and then designated appropriately as COVID or not COVID. So census, bed availability, cohorting the patients, PPE, that's a basic one. Do we have the protective equipment? We shouldn't even consider opening up until we know that what has been a moving target for everybody is no longer a moving target. If we don't have the capacity to safely, adequately, and appropriately put PPE on patients taking care of COVID patients right now, and not by lower standards, crisis standards of CDC, but appropriate infectious disease standards. If we can't do that now, and we don't have an adequate stockpile and a way to resupply that stockpile, then we shouldn't consider opening up until we do have adequate PPE to safely take care of those patients. So PPE, staffing, that's another criteria. People are burnt out and have been out straight for weeks now. When we redeploy staff back who have been assisting the nurses in the ICU back to their normal places of operation, like the OR nurses have been helping out, the PACU nurses have been running an ICU for the most part themselves as a COVID unit. When all of those folks have to move back to the regular units and be functioning in the pre-COVID capacity, that takes away a lot of the support for the ICU nurses who are burnt out, right, and really need a break. So we need to consider the capacity. Number one, do we have enough staff for those nurses to be able to safely take care of cohorted patients in the ICU on the med-surg floors with adequate supplies and adequate staff to support them, and in a way that doesn't have them intermingling. You cannot have, oh, there's not enough staff, go float so-and-so from another unit down to the COVID unit. We're going right back to the same problem we had in the beginning if we do that. We have to be able to staff them separately, which means considering giving these people some time off before we do this and having a plan to staff it appropriately. And the standards, clearly, when I say staff appropriately, we can't say we're going back to normal operations and then still have a waiver in place on the staffing ICU laws or any of the other staffing laws, as well as the mandatory overtime. Those waivers need to be stopped if we're going to reopen the beds to regular operations. You just can't have it both ways, right? I think the standards of care, again, that goes to the staffing and the PPE, that we're back to standards, not crisis standards. I mean, it's not appropriate to put in place saying we're going to measure you on crisis standards, but we're going to reopen based on normal operations. That's completely unfair to patients that we would be admitting to the hospitals, as well as the COVID patients that are already there. And I think oversight, I mean, we have to consider who's going to be oversighting this. We want to make sure that there's strong oversight, that there's transparency about what's going on, that it isn't just simply so-and-so said it was fine and therefore it was. We need to be able to know what are your benchmarks, what are your numbers, that they can be easily visibly seen by the public, and a way to measure if you're not meeting them, to do something about it. There has to be enforcement as well. And certainly the ability to change it if things change. So let's say that there's suddenly a surge up in COVID-19 patients. Well, if there's a surge up, you cannot have a circumstance where you have a dedicated med-surg floor, a dedicated ICU, then all of a sudden you've run out of ICU beds or floor beds and you say, well, we're going to start to commingle those patients, or we're going to reopen a surge bed and redeploy nurses as we did before. No, you cannot do that. If we're going to reopen normal operations, and there has to be a way to do the capacity of COVID patients at the same time. You cannot mix those worlds. If we don't have enough capacity to deal with the COVID patients because that population is growing, then we need to diminish again the elective surgery cases. I'm not saying completely shut them down, but there has to be a way of prioritizing and saying you cannot do surgery on a patient that may need an ICU bed when there are not enough ICU beds to begin with for COVID patients, as it were. So I think all of those, and last but certainly not least, is any of this, I mean, I've put out sort of some general concepts, but the meat has to be put on those bones. And in order to do that, particularly at an institutional level, the frontline workforce, the staff, nurses, health professionals, the others, the people particularly who have representation, such as M&A, they need to be at the table or Zooming meeting, whatever it is, and making sure that these are in place to their satisfaction before this starts up. So representation and discussion and negotiations over how this is going to happen are fundamental. I think that in order for it to reopen safely, you cannot do it without the people who are going to perform the work on the front lines. If what I said, if people are given the opportunity, afforded the opportunity to sit down and go over exactly what the plan is, and let's take a leap of faith that, you know, we don't extend out the stay-at-home order past the 18th, which could happen if we don't see any reduction in the mortality rate and we see more census going up again, then that has to be reconsidered. But let's say for the moment that over the next couple of weeks, the census of COVID-19 patients is going down, the mortality rate's going down, beds are opening up, and things look like we're past the sort of the peak and down from the plateau on the other side. If that's the case and the 18th is coming, then the parties should be sitting down and negotiate over exactly how the reopening and how people who are redeployed to the ICUs would be brought back to their units and how we would then begin to staff up. If that negotiations and that discussion happens and things don't dramatically change in the world regarding the numbers of COVID patients, then I would expect that we'll probably see some surgeries happening after the 18th, very small number, and certainly no patients that we are deeply concerned about are going to take up ICU beds. But the small number of cases beginning to get the work back into the flow, but then really in earnest, probably in June, after the beginning of June is when we'll start to see the cases begin to ramp up to a more normalized operations. And hopefully if the beginning of time that we have there over Memorial Day and the beginning of operations resuming is a perfect time to really allow some of these folks that have been just working like dogs for the last 6 to 8 weeks, afford them a little bit of time off and some emotional support, because when this is done, it is not usual for people to be working like this under reduced standards and the type of environment that they're in. I mean, I think it's going to hit them like a ton of bricks, and I think we're going to need to know that we need to support those folks and we need to give them a little breathing space. We can't just throw them into round two and say, hey, you know, just suck it up. That's not appropriate to do to people, and if we have any kind of care to our workforce, then we'll make sure that we build that into the system as well. So if things are done right, I would anticipate in probably June is when we'll start to see the resumption of cases. You know, it seems like forever that we've been waiting for some warm weather and forever that we've been waiting for some consecutive days of sun. So this is the past weekend that I think we've actually, on the third day of actually seeing a sunny day over the 60 degrees. So, you know, the public's anxious to get out, people are anxious to move on from this and start to see the summer is on the horizon. What I would say is this much: as we begin to reopen and normalize operations of our health facilities, you know, summer is going to move very quickly, and we need to still be taking the time during the summer to do a much better job of planning for the next round, because everybody is pretty much aware now that we expect another surge to happen in the fall. And that will make perfect sense, because we'll begin to reopen society, if you will, and therefore we will see more people infected. That's the nature of how this works. And so over the fall, as this happens and the infection spreads some more, we'll probably see a bump up in the cases. And there'll be more testing, so we'll definitely know of more cases as well, I hope. You know, that does not mean that we're going to do or have what happened this time around, in which everybody was put at a stay-at-home order, elective surgeries were canceled, the hospitals were opened up, and massive economic stimulus packages happened. I don't think that we should necessarily expect that's going to happen in the fall. Instead, I think what we're going to want to see is that people can be admitted to the hospital in a manner that's safe to treat the COVID patients, but still allow and maintain some basic health facility operations to continue in effect. And that I don't think the general public wants to be locked down again if they can at all help it. And the appetite for that, given the economy and the number of people that are really in dire straits right now, is pretty minimal. So I think there'll be a very big reluctance to do that. So if that's the case, our time to plan for that under those circumstances is this summer. And I mean that in terms of really setting up a mechanism that understands the level of staffing needs that we're going to have in the fall if these units become more robust with COVID patients. If indeed we need to expand out our capacity for COVID patients while not necessarily shutting down the rest of the hospital. We can't simply say, oh my God, there's a lot more COVID patients, but we can't shut down, so now we're right back to where we were, commingling patients and doing these crazy things and lowering the standards and going into crisis mode again. You should only do crisis mode once. If you do it twice, we are all at fault for that. So what I would say is let's start planning over the summer for what that should look like in the fall in the event that we see a surge coming back up again.